Hey, Hannah.
Hi.
You're gonna switch just to switch screens.
Yeah, I did. Can you see it now?
Oh, now it's good. Yep, you got it. Yep, you're good. All right.
I miss
Oh,
Zoom.
huh?
I miss Zoom. I'm getting used to.
I know.
I
Yeah.
can't figure out, maybe you can help me with this. When I do a Google Meet and I share my screen, I can't see everyone's pictures then.
Um,
And I couldn't figure out how to
yeah,
do it.
I haven't used it much with my
Okay.
team, so I
Yeah.
don't know.
Okay. I know it's a me problem because there's no way it doesn't.
I don't know. It might not be a you problem.
Yeah.
It could be a Google Meet thing.
Right.
I'll just mute my. Have any questions or anything?
No.
I didn't think so.
You time this correct? I guess I do have a question.
Yeah. Oh, good grief. Yes, I'm the one that, it's because Jules sets up the Zooms. Yeah.
Mm-hmm.
And in fact, we have no good way of doing it. So if you get to 5 minutes, I'll probably just interrupt you and unless you,
I probably will get to 5 minutes. I'm at like 27 minutes, but I'm timing myself too. So
okay. Um,
I like to know where I'm at.
okay. So I'll just say, I'll just do a quick 5 minutes or something left. Yeah.
Yeah, if you just like hold up your hand, but I'll
Yeah,
know.
I can just wave you. Well, can you see me though once you're
I
sharing?
I can see you right now and me. I don't know when more people come on.
You should, and you could scroll up so you could see me. Either that or I can put it in the chat. What would you
Okay.
prefer?
It doesn't matter. I'll yeah.
Okay.
I'm guessing yeah. My average is 27 minutes, but I might speak faster, so I don't know.
I just realized yep, I need to get the script here.
Oh yeah.
Pull the script up.
Eleanor, my mentor, is post call, so I told her she does not need to show her screen.
Okay. And let me yell at Kathy just a second. Yep, all right.
Hi, Sam.
Well, and I didn't think to remind you. And who's your practice mentor? Sorry.
Dr. Eleanor Colmenares.
All right. But Kathy knows that, right?
Yes.
Okay.
Hi, Hannah.
Hi, Sam. Thanks for coming.
You're very welcome.
I hear sweet voices in the background.
Yes, and this is after I asked them to leave me alone for the next half hour or so.
Well,
It's okay. You'll be muted,
I
so
was gonna say, I think the Ferguson babies are gonna be on, so.
It's okay. This is why I love mute.
yeah. Hey, Jewel.
Hi, Joel.
Hello, you
Hey.
guys.
Can you stop recording us?
Yes.
Thanks.
Gonna hear.
Well, good afternoon, everyone. And Thank you for joining us today. I am Dr. Melody Cash, and I'm the EMU co-director of the Goshen College EMU DNP Consortium. On behalf of Dr. Jewel Yoder, who is the co-director from Goshen, and the entire DNP faculty, I'd like to welcome you to Hannah Ferguson's defense of her Doctor of Nursing Practice final project. And thank you very much for joining us today. This is a very important day for Hannah, as it marks the culmination of 3 years of hard and sometimes very lonely work. Before I introduce Dr. Kathy Rittenhouse, who is Hannah's lead faculty, I want to make a couple of announcements and reminders. First of all, this session is being recorded, and we ask that all guests keep yourself muted for the duration of the event. We invite you to keep your video on so that we can have a feeling of community for Hannah. You will likely want to see the speaker view. To see that, you go to the top bar of the Zoom screen, and on the far right, you'll see an option for gallery or speaker, and you can choose the speaker view. So the schedule of the session is Hannah will have 30 minutes for her presentation. At about 5 minutes, I'll give Hannah a little wave to let her know that she's has 5 minutes left. And then after the presentation, there'll be a time for the audience to ask questions. You may either ask the questions verbally, or you can put them in the chat and I will ask them for you. And then after the Q&A session, we ask that everyone except Hannah's lead faculty and Jewel and I log off the Zoom session so that we continue to have a conversation with Hannah. And so now I will turn this over to Dr. Kathy Rittenhouse to introduce Hannah and her team and her project. Dr. Rittenhouse. You're muted.
Just figured that one out. Thank you, Melody. It's my pleasure to introduce Hannah Ferguson and her project, her DNP project. Hannah is a board certified family nurse practitioner who, in addition to teaching here at EMU, also practices in the community. The title of her presentation is Enhancing Postpartum Care Through a Structured EMR Checklist. This project was done in coordination with Dr. Eleanor Colmenares, who is a practicing partner at Hannah's workplace. So thank you, Hannah. We look forward to hearing your presentation.
Yeah, thank you. I look forward to sharing. And truly, thank you everybody for being here today. Okay, so I wanted to start off by giving you a little bit of context to what we will be discussing today. If it's helpful for you, I can make these slides available to you after the presentation. And those who have access to my paper, I correlated my contents of my presentation with the chapters in my paper for easy reference. Now, I'm very aware that most of you were at my proposal, and so these definitions might feel repetitive, but in case you weren't, I just wanted to make sure we were all clear on what I'm talking about today. So when I talk about the postpartum period, that would be the first 12 weeks after a person gives birth. Postpartum care is care administered by a healthcare provider during that time. And quality postpartum care is the inclusion of essential components informed by guidelines. And I'm going to introduce you to those components on the next slide. So these are the 8 essential components of postpartum care, and these are informed by 2 governing bodies. The first is the American College of Obstetrics and Gynecology. I'll refer to that as ACOG, as well as the Center for Medicare and Medicaid, also known as CMS, and they are the body that does merit-based incentive payment systems, or MIPS, and they determine what quality measures should be evaluated in a visit. So these are those 8 components: breastfeeding evaluation and education, postpartum depression screening, intimate partner violence screening, postpartum glucose screening if indicated, family planning, tobacco use screening and cessation education, healthy lifestyle and behavioral advice, and immunization review and update. And what I mean by postpartum glucose screening if indicated, that means if someone had gestational diabetes in pregnancy, they get that glucose screening during the postpartum period. So it's not all postpartum patients, but rather a select few. So when I'm referring to quality postpartum care, I'm referring to the inclusion of those 8 components. But there's a problem. Postpartum care, evidence tells us, does not always include these 8 essential components. And if you think back to what these components are, a lot of it has to do with prevention and health screening and education. And so what the literature tells us is that when these components aren't included in care, this negatively impacts not only the postpartum patient, but also their family. And if the care is given but not documented, this further impacts subsequent care as well as like incentive-based reimbursement through MIPS. And so I just wanted to give you an idea of what happens when even one of these components are not included in postpartum care. And so I have 3 I'm just going to introduce you to. So let's talk about intimate partner violence or IPV screening. If someone is experiencing IPV in the postpartum period, that obviously leads to negative physical and emotional outcomes for the client, but studies have shown us that it can impact that newborn's development and lead to delayed bonding, and it can further expand out to the family and housing insecurity. With gestational diabetes follow-up, we know that 50% of gestational diabetics will go on to develop type 2 diabetes. And you don't have to be in healthcare to fully understand what that potential comorbidity and sequela could look like for that client. And so if you miss that screening opportunity, you potentially can lead to those devastating effects. Postpartum depression screening, the literature tells us that late recognition and treatment leads to higher negative outcomes and risk of complications for the patient and developmental delays for the newborn. So these are just, if one of the components are missing, right, it can have detrimental effects. So with that in mind, the purpose of my project was to enhance the quality of postpartum care through the inclusion and documentation of those 8 essential components. And my resulting clinical question does the use of a structured EMR checklist improve the quality of postpartum care through the coverage of essential components for clients who received care within 12 weeks of giving birth? I'm going to introduce to you the project site in a bit, but to even start off and see if this project made sense at this organization, I did a SWOT analysis informed by Harrison, where I looked at strengths, weaknesses, opportunities, and maybe threats to the project. And I presented this in my proposal, so I just want to highlight a few things that were happening at the practice before my project. So the strengths of this practice is that they provide excellent medical care and support to postpartum clients. The weaknesses was that there wasn't a standardized way to capture this information in the postpartum visit, and they didn't have any standardized process from provider to provider. A threat to the project was that only 14% of my survey participants were aware of what all the 8 essential components of a postpartum visit were. So we felt like this highlighted the need for the project as well as readiness for the project. In order to see where we were at with the 8 essential components, I did a chart audit from January to October of 2025. This resulted in 179 6-week postpartum visits. You can see here, these are the percentages of completion, and there were strengths. So strengths of the organization, breastfeeding evaluation and education, postpartum depression screening, and family planning counseling. Those were all being done at greater than 85%. However, I do feel like it is worth noting that it wasn't always done in a systemized way, person to person, or even visit to visit. Other results, tobacco screening was being completed 26% of the time, healthy lifestyle and behavioral advice 11% of the time, gestational diabetes follow-up was 14%, and at the time of the project, there was no systemized way of screening for intimate partner violence or IPV, and therefore one of the interventions in addition to a structured EMR checklist was the implementation of the evidence-based screening tool eHITS, which would screen for intimate partner violence. There were facilitators and barriers worth mentioning during the project. I think the biggest and likely most important was leadership engagement. So the leadership at this project site named this as a need prior to me as the DNP student entering the conversation. And they're active practitioners at the site. So they're engaged with this data and these clients in real time, and their support and engagement during the process made a big change. The barriers to the project was that this was a new practice site. So when I started the project, they were entering into their only third year of practice. And how we worked to kind of mitigate this barrier was to lean into the culture of change that was naturally occurring within this new workplace. And there was an adjustment to the change in the workflow, and we mitigated this by trying to provide staff support through staff meetings and receiving feedback from them, as well as surveys to check in. This project was also informed by a review of literature. Again, this was presented in my proposal. You can see the keywords, the inclusion criteria, the exclusion criteria, and that led to about 22 articles. And there were 3 themes that I am going to review again today because I feel like they are pertinent to the project. So the literature said, 1, technology can and should be used during the postpartum period. 2, disparities exist in the postpartum period. These include both racial and socioeconomic. And 3, there needs to be a priority of screening in that postpartum period. And what I feel like highlighted a need for this project based on this literature review is that there was not one tool studied and that gave evidence to, yes, this should be used in the postpartum period to enhance care. And so there my project came. We applied a theoretical framework to this project. We used the PDSA, or the Plan, Do, Study, Act model informed by Deming. I did 5 3-week cycles through the course of my project. In the plan phase, the goal was to improve the quality of postpartum visit documentation, and my plan for data collection was utilizing a chart audit tool, which I'll introduce you to. And my guiding prediction was that this EMR checklist and my interventions were going to enhance the quality of postpartum care. During the do phase, we implemented either the checklist or the screenings, as well as new interventions, and we had staff meetings to collect those observations, which I documented in a narrative format. During the study phase, we looked at nominal descriptive statistics. Particularly, we were looking at percentages and frequency rates, and that was compared to the guiding prediction of if it was improving quality. We looked at disease burden within the population to see if we needed to have any additional interventions for a specific population. And we looked at staff confidence of 2 things. 1, administering an IPV screening, and 2, responding to a client who screens positive for IPV. Based on that study phase, we then made interventions that were informed by data and improved by my DNP project team, and then implemented in the next PDSA phase. The conceptual framework that was applied to this project was the self-care deficit theory, and this was the overarching understanding that postpartum is a vulnerable time and self-care deficits can occur. And the founder of this theory, Dorothea Oram, says that a self-care deficit is when one's capacity for self-care is kind of imbalanced with other things going on in their life. And I think that makes sense for the postpartum period. But to give you an example of this, one of the interventions, or one of the essential components, is screening for postpartum depression. And when we saw a certain positivity rate of postpartum depression, we created resources to help those clients meet their needs and promote self-care. I want to be really clear when I talk about who the participants were in our study. So it was extracted EMR data from a visit that had already occurred. And so the selection process was all 6-week postpartum visits that occurred during the project timeframe. The inclusion criteria was that the client had to have given birth within 12 weeks. The visit had to happen during the time frame, and the chart had to be accessible to me as the DNP student. And if the postpartum visit included a fetal demise, we did exclude those from the project. And so this led to 78 6-week postpartum charts. Again, this doesn't represent like individual patients, but I did want to give you a kind of demographic of who the participants were in the study. You can see the mean age was about 29.64. Parity, or number of times given birth, was between 1 and 6 with an average of 2. And the participants were predominantly white with private insurance. To introduce the setting that this project occurred in, it was in a low-risk prenatal and primary care visit. As it was highlighted in the SWOT analysis, this clinic did a wonderful job at providing support in the postpartum period, and all clients who delivered with the clinic were offered a 2-week and a 6-week postpartum visit. However, in conjunction with my DNP project team, we made the decision to put this checklist and interventions within the 6-week postpartum visit because the 2-week one focused mainly on lactation. And so the 6-week visit was where we can kind of fully holistically encompass all of those components. So in order to evaluate our project, a chart audit tool was created, and this essentially was looking at the documentation of the 8 essential components. If it was documented, it was coded as a 1. If it was not, it was coded as a 0. And again, I want to kind of make a statement about clarity here. I wasn't just looking if it was documented in the checklist. I was making sure that it was actually represented within the client visit. So if you said you did postpartum depression screening, did we see the EPDS completed? So it wasn't just looking at the chart list, it was looking at the full picture. We looked at age and parity and race and insurance status, as I just mentioned. The reason why that was done was because we were stratifying the data throughout the project to look for any disparities that might be occurring. And then we wanted to see disease burden. So we looked at the EPDS, which is a validated tool for depression screening postpartum. And within that screening tool, you can actually take 3 of the questions, and there's a validated EPDS 3A that evaluates for postpartum anxiety without the client having to do any additional questions. And then we looked at the scores to the EHITS IPV screening. In order to assess for staff confidence, I created a linear scale survey that went out to all staff at the project site that asked them how confident they felt in administering the EHITS and then responding to a positive. And they would do it on a linear scale, 1 being I'm not confident at all, 5 I'm very confident. So here is a comprehensive list of what the interventions were. They were informed by data, and they were all approved by the DNP project team. One thing to note is that once they were implemented, there were no interventions that we took away, so they remained embedded throughout the duration of the project. In PDSA 1, we introduced the structured EMR checklist as well as the EHIT screening tool. In PDSA 2, we put staff reminders of the essential components on all computers of rooming staff. We hosted an IPV Lunch and Learn with a local IPV specialist to work with staff on screening for IPV as well as responding. We translated the EHITS into Spanish and Arabic by medical interpreters. In PDSA 3, we created a resource. These were 2. One was a mental health resource list of where people could be referred to in the area. And the second was an algorithm for what the staff could do if a patient screened positive to IPV. In PDSA 4, I conducted one-to-ones with staff regarding the checklist and created postpartum exercise and coping with postpartum anxiety handouts that were sent out to all postpartum clients at the site when discharged from the hospital. In PDSA 5, we did a gestational diabetes process change. So we found that when someone delivered and they had gestational diabetes, and I mean deliver a baby, their gestational diabetes problem would fall off their list. So the provider at the postpartum visit couldn't see what their diagnosis was. And so they'd have to go back into the labs, and it was a little bit clunky. So now when a client delivers at the project site, we document history of gestational diabetes so that stays with the client throughout their entire care at the practice site. We expanded our IPV screening to all first OB appointments, so it's occurring at the postpartum visit as well as new OB appointments. We updated the HPI component of the postpartum encounter template to be more like a checklist drop down instead of free typing. And what evidence really showed me during this project was that IPV is underreported. And so really they recommend universal education. And so I created evidence-based handouts to go out to all pregnant individuals at the clinic site, as well as all postpartum clients that provided information and resources on IPV. And this just gives you an example of what the structured EMR checklist looked like. Providers would have the option to select different choices. So the outcomes that we looked at were the percentages and frequency rates of completion for the 8 essential components. And I used the Intellectus software to do statistical analysis. A chi-square test of independence was utilized on 7 of the 8 components, and a Fisher's exact test was utilized on gestational diabetes follow-up. And the reason for that was I just had a smaller sample size. Screening results, we again looked at disease burden for the postpartum depression, postpartum anxiety, and percentage of those at risk for IPV, and then looked at the average confidence levels of staff responding and screening for IPV. Here is a list of some resources that we utilized during the project, and I think the biggest one was EMR training for me, and then time for myself and the staff. And here you can see a timeline when the project started and the different interventions that we utilized. But now I'm excited to talk about the results, why you all are here. So I am happy to report that there is a positive increase in completion of all of the components. In addition to that, there was a statistically significant change in all of the components. Another way that I did data analysis was doing run charts, and those run charts showed sustained data points above the median, long runs in the positive direction, and reduced variability. About 10% of our clients screened positive for postpartum depression, 27% screened positive for postpartum anxiety, and we had about a 4% positivity rate to IPV. In staff confidence in administering the IPV screening, we had a range of 4 to 5 and an average of 4.5, indicating they felt pretty confident administering the screening. But you can see here, responding to the screening, we had much wider variability between 1 and 5 with a mean of 4. I don't have this presented to you, but I will say as the PDSA cycles went on, variability decreased, and we were a little bit more confident after we implemented certain interventions like the lunch and learn and the algorithm. So here you can see a visualization of the results. On the left, you can see the navy blue. That would be percentage of completion prior to the project, and the orange would be post-completion. And over to your right, you can see percentages of completion for pre-project, each of the PDSA cycles, and then post-project. And then on the far right, you can see that we had a positive percentage point change of at least 10% in all of the 8 components. So here are the chi-square test results looking pre and post project. And if you look briefly over at my p-values, all were determined to be statistically significant. Here is the Fisher's exact test result for gestational diabetes follow-up. And we had an odds ratio of 27.24, meaning that people in the post-intervention group were 27.24 times more likely to receive appropriate gestational diabetes follow-up than the pre-project group. So if you would like to look over my run charts after this, I have a hyperlink here where you can see all of the different run charts for the 8 individual components, but I wanted to present kind of an overall compliance run chart score. And so this is looking at compliance to all 8 of the components throughout the project. And you can see where different PDSAs started and interventions were included. And to highlight, we really did go from a compliance score of 0.389 to a peak of 1 during the project. As you can see, after most of the PDSA cycles, we saw a shift in a positive direction. There was just one area in PDSA 4 that I've highlighted for you with a red arrow where we saw a little bit of a decrease in compliance. We were above goal, which I should have said our goal was to be at a greater than 75% completion rate because that's what's required by MIPS. We were still above goal, but what happened there was the site actually had an outbreak of influenza. And there was a provider who was having to room their own patients. And so we saw a decrease in compliance. However, you can see as soon as staff returned to their normal roles, we had a positive compliance change. And to me, that just really highlights the importance of interdisciplinary care and the importance of everybody working together. And it's not just a siloed project. So Why do I think that we saw an increase in completion, and why do I think we saw a statistically significant change? Well, let's start by talking about things that the site was already doing well. If you remember, breastfeeding, postpartum depression screening, and family planning were already being documented 85% of the time. However, once we introduced a systemic process for documentation throughout the project, it was documented 100% of the time, highlighting the importance of systematic documentation. For IPV screening, staff responded positively to this change in workflow. If you look back at the completion rates, we had 100% completion rate of IPV screening in every PDSA cycle except for one. And I attribute that to staff education and staff familiarity with workflow. They were already used to doing screenings, and so they seamlessly added in another one. The one area where we did not have 100% completion rate was a client who came in who spoke Arabic, and we were not able to screen this client for IPV. And so that's why we did the intervention of translating the e-hits into other languages. And that highlights the importance of equitable healthcare, where you're able to screen and provide healthcare in the language that the client prefers. Tobacco screening and healthy education, I will get into that on the next slide. But with immunization review and update, this just, I think, saw a change because of education. This was already being done within the pregnancy, and once we provided education to also have that included in the postpartum visit, we saw an increase in compliance. And gestational diabetes, the analysis is the process change. Staff were able to easily see who had gestational diabetes in pregnancy and who did not without having to go through a bunch of labs, and that sped up the process and being able to get screening. So here is a run chart for my healthy diet and exercise and tobacco use. What you will likely see is more variation in the healthy lifestyle screening and education as opposed to tobacco screening, and that's because tobacco screening is more binary. Do you use tobacco? Yes or no? While as healthy lifestyle screening is more nuanced and involves a lot more questions. You can see that compliance towards the ends of the project was positive. There were two areas that I just wanted to highlight, and coincidentally, they both kind of overlap with each other, and they were both in PDSA cycle 2, and you can see them referenced with red arrows there. So we saw an initial decrease in compliance with that first arrow because we had staff who were rooming patients who didn't work on the day we did the education or were on vacation. And so they came into the room and hadn't been provided the education for the EMR checklist. And so how we kind of met that was we provided the staff reminders that I talked about in PDSA cycle 2 that went on all computers. The second red arrow that you will see was when staff had kind of responded to that initial staff reminder on the computer, but they weren't dating their entries. And so they were doing the work, but we couldn't count it as being done. And so the staff supervisor made a process change where she had all of the rooming staff date all of their entries. And again, the reason why I think we saw a statistically significant change is because it was a systemized and systematic process for documentation. Postpartum depression screening with that 10% positivity rate, this highlighted the importance of consistency and documentation and identifying those at risk for postpartum depression. Anxiety was actually a more common concern, and that showed us the importance of mental health screening and intervention. And we had about a 4% positivity rate for IPV, and this is significant since we know that IPV is also underreported. And so any positivity rate is significant and was important for screening. Staff confidence, as I had mentioned, why I think staff felt much more confident administering the IPV screening than responding to it is one, because IPV is a highly complex and sensitive issue, and I don't really ever expect people to feel completely confident in responding to it. However, when we did interventions like the IPV Lunch and Learn and other resources, we did see more comfort with this. So my recommendations going forward was that this would become a permanent practice change within the practice site. You can see additional recommendations listed below that. And the implication is that this will improve the quality of postpartum care and subsequently increase MIPS reimbursement for the site. There were some limitations that are important to be named throughout the project. First, this was a single site implementation, so it was one site that I conducted the EMR checklist at. It was a convenient sample, so it was all postpartum, 6-week postpartum visits, and it wasn't randomized. There was a limited implementation period of the project, and I relied on pre-existing records as opposed to intersecting with the data in real time. My plan for dissemination, the target audience primarily is the practice site. However, we do want to expand this to reproductive health providers and even healthcare providers in general. What we are kind of finding at the practice site is that a structured EMR checklist can be implemented in a variety of visits to ensure those quality components are included. An example would be hypertension follow-up or diabetes follow-up. So we do think that it's worth disseminating to broader than those just caring for those with reproductive organs. We've submitted to present this project at the Virginia Neonatal Perinatal Collaborative in October of 2026, and we're currently writing the abstract to submit to the Association of Women's Health Obstetric and Neonatal Nurse Conference, so both locally and nationally. And our plan is to submit for publication to the Journal of Obstetrics, Gynecologic and Neonatal Nursing with the goal to have that ready by December 2026. Here are some of my references available for you. There's a much more extensive list in my paper. But I just wanted to take a second with my last 3 minutes and say thank you and give some acknowledgements. First to my DNP project team, this was Dr. Kathy Rittenhouse and Dr. Eleanor Colmenares. They provided me with wisdom and expertise. They met with me during each PDSA cycle and approved my interventions. They helped me understand data, provided emotional support in more ways that I could say, and I could not have done this project without them. So thank you. To the program co-directors, Dr. Cash and Dr. Yoder, I feel incredibly grateful to be in a program that focuses on core components like peacemaking and human flourishing, and that is directly related to your leadership, so thank you. My DNP cohort, Jen Walters and Margaret Furr, provided emotional support, and other supporters, of course, included Dr. Ann Schaefer, who really helped me with data analysis and understanding run charts, as well as several others. And that's it. Thank you. Thank you.
Thank you, Hannah. This is our opportunity, or this is the opportunity for the audience to ask Hannah any questions that they may have. Please feel free to unmute yourself and ask a question or pop it into the chat. Hannah, you can unshare your screen if you want now.
Okay.
Yep, we'll just open it up. You can also offer congratulations.
Congratulations. I have a question about what community resources are available in connection to items on the checklist. For example, IPV. Does the practice site have a relationship with a local domestic violence services, or what does that look like?
Yeah, thank you. Really good question. And we do now. So that was part of the IPV Lunch and Learn. It was done with the local IPV response service and safe housing in town. And so they came in and provided the education to support staff, but they also brought in resources for our clients that they could have direct access to the safe house and the counseling services and the legal resources that they provide.
And those are maybe like cards or QR codes in the bathroom or private spaces that they can access?
Correct. And the exam room. Mm-hmm.
I had another question about the Arabic speaking client. When the IPV screenings are administered, are they handed on a piece of paper, or is a practice person reading it aloud?
Yeah, Kathy and Eleanor can speak to this. We went through a little bit of a trial and error. So at the practice site, everybody should get the screener prior to their visit where they can complete it on their phone. If they have not completed it on their phone, then we give a handout in the room. And we were trying to kind of problem solve with, do we do that in the room? What do we do if there's a partner in the room? And so that's why our goal is to have it completed on the phone privately before they arrive. But if that doesn't occur or they had some technical issues, we give them a paper handout.
Interesting. I'm having two thoughts. One is that the perpetrator of violence could be there with them and is likely controlling their phone, right? So they can't do it at that point.
Mhm.
Second, I was just wondering, would there have been an Arabic speaking person available to read the questions to that person if that was a safe scenario to do so?
And I think the staff who rooms the client, it was really early in the project, maybe wasn't as
Okay.
familiar with the screening questionnaire. And I'm wondering if that had happened later in the project when we had done all the training, if they would have felt more comfortable verbally administering it if they assessed it to be safe.
Sure.
Yeah.
Um, and then my last question relates to breastfeeding education and actually in the prenatal period. Is that part of prenatal education starting talking about breastfeeding? So at this in the postpartum period should be a repeat of things that they've been hearing throughout
Uh,
their gestation.
yeah, so it's not necessarily always included in outside resources, but at the practice site, the 36-week pregnant visit is a breastfeeding support visit if they choose
Oh,
to breastfeed. Yeah.
thank you.
Yes.
Hannah, great job. Just absolutely phenomenal presentation and project. Having had you in class a couple of years ago and hearing a little bit more about your organization, I would consider them innovators and early adopters on a lot of things, at least the way I understood the organization. But while you seem to indicate, um, like not I hate to use the word compliance, but like people were excited about the project, were willing to make the changes, but were there times when things were going a little bumpy, some level of resistance that maybe was unspoken or spoken, and how did you work with that?
Yeah, that's a really good question. I would just like to echo that absolutely. This site is an APRN-led clinic. And so with that comes just the general characteristics of nurses and continuing wanting to promote quality and excitement about providing the best possible care to our population. I really expected a little bit more pushback than what I got, particularly around IPV. I was kind of anticipating people feeling a little bit more resistant to that, but I think when we had that IPV lunch and learn and people shared stories, that was one of the ways that we really facilitated engagement was hearing from personal experiences that even staff had experienced and sharing with each other and highlighting this is why it's important. You wouldn't have expected this with me, right? And so one of the ways is we really personalized the topics. We did have a little bit of a struggle when we had that influenza outbreak, and that had to do with people just not being in their normal roles. And so what I truly did is we just rode the wave, and when people came back, we waited to see if there was compliance, and there was. Does that answer your question?
Yeah, absolutely.
Okay.
And if nobody, I have another question, but I want to let somebody else
Okay.
ask.
Go ahead, Don.
Well, I was starting to type it in chat. So, Hannah, is there enough data in the organization that, say, in a year from now, you and a research team, not a QI team now, but a research team, could look not just at compliance with checklists, but actually look at what impact this checklist has on patient outcomes. And because there were, what are there, 8 guidelines, maybe you'd want to focus, but you know, don't know what the measures would be, but just thought that with that, is the organization data rich enough historically that you could do some pre-post stuff in a year?
My thought would be yes. Again, I think that has a lot to do with the type of the organizational it is and the desire for quality improvement. We also have several APRNs who want to get their DNP anyway. And I know you're talking more research than quality, but there's this continual spirit of understanding and researching more. I don't have exact numbers to give you, but my thought would be yes. Yeah. And we actually will be, I mean, we're going to continue to evaluate this because this is outside of the project scope, but in submitting for reimbursement through that merit incentive-based program, we have a dashboard that's within the EMR that will say what are our compliant rates to these components. And so one of my suggestions in the plan going forward was that we have a quality improvement team at the site who pulls those reports at least like 3 to 4 times a year and just see where we're at, which may be a little bit different than what you're asking, but I think it kind of funnels into, yes, it could happen.
Yeah, I was thinking more about like, number of patients or percent of patients that quit smoking or have fewer
Oh,
complications, that kind of more patient outcome,
yeah.
improved health experiences kind of thing. And I
Yeah,
guess, and there's a part of me too that given that you're reporting data for reimbursement, there's data that's already there. It's just a matter of mining it and analyzing it.
yeah, which may or may not be Hannah Ferguson because research might not be. I
That's why I said a team.
think. Right.
I would just like to affirm, I think it's really important that you mentioned that you do the IPV screening at that first OB visit. We know that IPV increases during pregnancy. And I think a lot of disclosure of IPV is relationship based. And so that very first visit, you probably aren't feeling that connected maybe yet to your provider, but by the time you're either at the end of pregnancy or at postpartum, you have established a long relationship with hopefully those providers and can disclose it. So I think starting that conversation early and indicating this is something we do for everyone and it's routine is really good groundwork for cultivating disclosure.
Yeah. And I think the unique thing to highlight that is yes, that's what evidence tells us, but that was actually a request from staff to expand it out to other areas, which felt really important.
Yeah, I love that you brought that up because that resonated with me as well as Hannah was presenting this. And even like you said, just setting the stage for it. And it could be something like, we're not going to ask you this every single time. But again, know that we're here. We're aware that this could happen at any point to anybody. And we're just a safe place. So you're setting that foundation for, yes, I may not have ever met Hannah before this, but as I get to know her, I'm feeling more comfortable in telling her things. So yeah, great point.
Are there any other questions? So before we sign off, if anyone would like to unmute and just say congratulations, you are welcome to do that.
Congratulations.
Congratulations! Yay!
Way to go, Hannah.
Thank you.
Well, at this time, we will invite our guests to say goodbye, and we'll just keep Kathy and Jewel and I on with Hannah for the next part.
Thank you all for coming.
All right, congratulations, Hannah.
Well done.
Great job.
Yay.
Great job.
So good.
Yeah. So we'll take a short, Jewel. All right, Hannah. So this is the opportunity for us to ask any other questions that we have. And yeah, we'll just move right along. Kathy or Jewel, do you have any questions?
I don't have any questions.
The only one I have, Hannah, and again, just such an absolutely amazing presentation is, you were just like wildly successful in this project. I think from what we would be looking for in a project. And some of your data sort of suggests to me, not knowing your organization, but it seemed, again, very heavily Caucasian, very heavily private insurance. I really love that all the places that you're going to disseminate this to get it into the hands of others. But like, is there a health center? Is there a federally qualified, like low income clinic? Like, is there any way? Because, again, again, domestic violence can impact obviously anybody. It does not discriminate. But I kind of did the math of the numbers you shared with us, and it looks like maybe 3 people kind of got flagged for that. Well, like
Mhm.
would
Mhm.
those numbers be more drastic if it was already people that were living in, different socioeconomic sort of things? So again, I'm just sort of pushing you of like, it's such a good thing. Can you take your show on the road even locally to try just to continue to have impact in
Yeah.
kind of your local community?
Yeah, it's funny you say that. My job before this project site was at an FQHC, and that
Okay.
really is where my heart is. And I said to my husband, I've never done a project where I say it was predominantly white and insured. So it
Yeah.
was very different for me. So that's been a conversation that I've been having. One of our colleagues here at EMU still works at the FQHC.
Okay.
And she had the suggestion that they have staff meetings once a month and coming in and presenting at that staff meeting because they do postpartum visits there and seeing if we could maybe do it on a trial basis with that FQHC to see if we have the same success because there's going to be so many more languages, so many more socioeconomic implications. And to be honest, it's larger. And so there might be a little bit less of a buy-in. And so her recommendation or suggestion was to actually try it at an FQHC. Now, whether that will happen, I don't know, but I do know the executive director, and I have an email drafted to send to her to see if that would be plausible.
Just be really exciting, just
Yeah.
as sort of an aside. It's maybe not getting into the research that Don was doing, but I'm like, I want to see the impact now,
Yeah.
sort of
Yeah.
thing.
Yeah.
So love that.
Yeah.
Very
Yeah.
cool.
Thank you.
Hannah,
All
did
right.
you? Oh,
No, go ahead.
I don't think I remember seeing this, but even informally, did you look at any balancing factors? Like, did it increase time, or did you any subjectively, like people say, oh, this is taking us a lot of time? Was there anything that you like, yeah,
Yeah.
looked at
Yeah. One of
there?
the challenges I had with this presentation is like not being able to just say everything.
Mhm.
So if you remember in PDSA 5, one of the interventions was updating the HPI component of the
Oh,
postpartum visit. Because what people were saying is they were typing in all the information free type to match it. And so that's why we did a drop down to try to minimize patient time. Because it was PDSA 5 and I didn't really have a good way to track the time, anecdotally, they said it helped a ton. But that was the one area. Yeah.
And I'd even say, like, I don't know if this goes into that too, but just recognizing like some people missed the training and then you saw some things happen and we're like, okay, like how do we sort of correct for the like
Yeah.
the training wasn't mandated for everybody, or obviously everybody couldn't come to it. So that's another sort of like
mhm.
maybe it's not considered a balancing measure, but yeah, good pivot.
And that's why we had to do the intervention in PDSA 4 of the one-to-ones with staff, because when I actually ended up collecting staff who roomed patients, and I could see that there was like 2 staff predominantly who weren't completing it.
Mhm.
And that had a lot to do with a lot of things, but we met one-on-one and then we saw an increase in compliance. Evidence-based would call it microeducation, but
What point are you going to be able to track, or maybe there's nothing in this that does this tracking, but if I'm understanding, MIPS gets you reimbursement. We're kind of doing the right thing. So certainly your organization would have like a pre this of like kind of what you were getting in like 6 months from now, or however long it takes for the reimbursement to get to you guys. Like, is there a way to see like now that we did this, has actually netted us X amount of dollars?
I think in theory, so I didn't understand how all this worked. It took a lot of quality improvement training, but essentially you have to submit for 6 categories to get reimbursement for MIPS. So postpartum is actually just going to be one. So that's why my recommendation is for us to do the quality improvement committee so that we can look at hypertension, like things I know we're doing well, hypertension, childhood immunizations, diabetes, getting A1Cs and foot exams, etc. And if we have 6 of those that we're in compliance for greater than 75%, we can submit for MIPS. So they're not even submitting yet. So anything we net is going to be improvement.
Okay.
Wow, but then like what great, like you said in your presentation, like now that we've done a checklist, like yes, each checklist is unique, but like it sets the groundwork for
Yeah, yeah.
okay.
And
Oh, so
what I
much documentation.
Yeah, well, and so what I did, and again, I didn't share this in the presentation and maybe I should have, but I mapped all the diagnosis codes that went with the checklist. So they automatically populated within the visit and that way they don't have to do anything extra with documentation.
This is a great project, Hannah. I'm super impressed.
Thank you.
All right.
I don't
Are
have
we
anything.
ready to be whisked away into our?
We are ready. We're ready to be
We're
whisked
ready.
away.
All right, Hannah, you'll recall we're gonna step aside for 1 second here. I'm gonna just
Well, congratulations, Dr. Hannah Ferguson.
Thank you. Thank you. Thank you.
We all were so impressed. We're impressed with your work. We're impressed with the process you used. We're impressed with the outcomes. We are just very proud of you and very happy for you. And we really want to see you get this published because I think that this is so applicable to any place that, first of all, that does postpartum care. It sets the example for that. And then as you said, it can be extrapolated to so many other areas. It's a process that has such potential. So excellent work.
Yeah, thank you all. I really appreciate it.
Yeah. Yeah. I only have to say congratulations and go celebrate.
Yeah, exactly.
Celebrate.
Thank you. Thank you.
Yep.
Thank you.
Yep.
All right.
Hannah, since I drive the controllers here, which is really wild with my technical skills, but once this comes through to me as a recording, I will then convert it to YouTube just because
Okay.
Zoom we only have for X amount of time. And I
Okay.
will ultimately share that Zoom link with you. So you'll have
Okay.
access to your recording for your kiddos or whatever, whoever is dying to rewatch this at some point.
All righty. Well, thank you so much. I appreciate it. And I can go ahead and submit my paper in the repository. Okay.
Yeah, I don't think there were any things that needed to be. You can go ahead and submit and you've
Okay.
done all the other things, I think. So
Yeah.
Yeah.
Mhm.
Wow.
we'll have that degree conferred at the end of summer. Unfortunately, we can't confer the degree before the end of the day,
Oh,
but
that's
you
okay.
can call yourself Dr. Ferguson and you can sign Dr. Ferguson, or you can.
Oh, thank you. I really appreciate you all. Thank you so much.
Yeah, great job, Hannah.
Thank you.
All right, everybody enjoy the rest of their day. Hannah, celebrate.
Yeah, thank you.
Mhm.